Good afternoon, everyone, and thank you so much for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, COVID-19 updates and pediatric vaccines and new vaccine technology. Just a reminder that this educational series is generously sponsored by a partnership between the California Medical Association and the California Health and Human Services Agency. Next slide, please. Here are our speakers' disclosures today. Next slide, please. And we're going to hear from Dr. Erica Pon and Dr. Paul Offit, which I'll talk about in a moment. Next slide, please. And just a reminder that we do provide CME for this series. So after the completion of the webinar this evening, you'll be sent a survey where you can attest to your attendance. And if you complete that survey, we'll send out your certificates. Next slide, please. It has been a summer of what might be called a new normal, which of course is not normal at all. The extremely contagious variants of COVID-19 have raced through the community again. They seem somewhat untamed, and as formal testing declines replaced by at-home tests, we often don't know how many people are actually sick. As people return to pre-pandemic style gatherings, travel, and other activities, often without masks and other precautions, we watch and wait for what's going to evolve in COVID-19. With our currently available vaccines, however, we do have quite effective protection from serious illness and hospitalizations. And now we finally have the opportunity to vaccinate our youngest patients. At the same time, new vaccines made with old vaccine technology are becoming available, and new versions of the current COVID-19 boosters are being targeted towards recent variants. So many questions still continue about how this wily virus will next attempt to evade our defenses. So in this session, we're very excited to hear from California State epidemiologist, Dr. Erica Pon, about the state of COVID-19 in California. And we are incredibly grateful today to be able to hear from one of the country's most articulate, brave, and experienced vaccine experts, Dr. Paul Offit. First, let's begin with our friend and regular presenter, Dr. Erica Pon, and then I will introduce Dr. Offit. Erica?
Great. Good afternoon, everyone. Thank you so much for joining us. Let's go ahead to the next slide. I want to be really brief this afternoon because I'm just so excited and honored that we do have Dr. Offit here with us, but I wanted to make sure, since this is taking up most of our public health time right now, to give you just a few quick updates on monkeypox here in California, and then a little bit about what's going on with COVID-19 in California, and then I will turn it over to Dr. Offit. Next slide. So many of you may have heard and know that last week we did declare a state of emergency early in the week in California, and then that was followed actually by a federal declaration of emergency to support monkeypox response. And really, I think what this helps do is really mobilize resources, hopefully opens up some flexibility so we can collectively at all levels really respond even more nimbly to this new emerging disease in California. Next slide. So this is actually already quite outdated, but just to show you sort of, we've been updating our data twice a week now, so we'll have more data this afternoon. But as of last week, at the end of the week, we had over 1,300 cases of monkeypox in California. You can see in our epidemic curve here, it continues to increase so far. It's in over 29 local health jurisdictions. We have had 27 hospitalizations, and thankfully no deaths here in California. It's been about 3% or so of the cases that are hospitalized. Early on, it was, I think, certainly because a newer disease that people are less familiar with. Sometimes it's pain control or other super infections or other reasons that people have been hospitalized, but it is certainly starting to see some morbidity there. And so we're keeping a close eye on that. We've also had our first few pediatric cases here in California. They were of household contacts of known cases, but that's also potentially an emerging change as far as the epidemiology of the disease here. Next slide. Also wanted to share, because we were really the first in the country, and I believe in the world actually, to detect monkeypox due to actually some academic partners at Stanford to see monkeypox in our wastewater surveillance. And this is kind of an illustration of where we're seeing it more consistently and where we're seeing it more intermittently. But certainly a lot of the testing actually started in the Bay Area, in the San Francisco Bay Area. We've also seen a little bit in Southern California intermittently as well. We have not yet seen it in Los Angeles County, although I think the sort of overall population, I think, is much larger. So we're not seeing the detections there, although certainly that's where 2/3 of our cases about are in either San Francisco or LA County. So this is something we're watching closely as well, as far as just the levels of detection in our wastewater, and another great infrastructure we helped build during COVID that we are now leveraging for monkeypox. Next slide. And then just want to highlight again the treatment for monkeypox. It is another antiviral. It is thankfully available PO and largely has been given orally, and it's a 2-week regimen. It is still under IND, although I think a lot of the paperwork, et cetera, is being streamlined further. Patients do need a very detailed informed consent and follow-up, and it's still only available through the National Strategic Stockpile, so it gets ordered from us at the State Health Department, and then we in turn send that to local health departments. So if you are not already a treatment site, please do contact your local health department if you're interested. We have over 80 sites right now that can provide oral treatment, and over 8 hospitals that can do the IV. To date, we haven't actually heard of anyone needing the IV treatment, and again, the oral pills are quite tolerable. Next slide. And these are a repeat for those of you that tuned in last week when Dr. Chin Hong was here. He actually shared one of his patient experiences, and also just to kind of highlight right now what the recommendations are about who to treat. So if people are hospitalized or are very severe, if there's confluent rectal lesions, severe oral ulcers, or certainly eye involvement, these can all be incredibly painful as well. Or certainly if someone has severe immunocompromise, in our pediatric cases, pregnant or breastfeeding persons, or other sort of underlying diseases or other potential reasons to treat. I think it's going to be an ongoing conversation about there's less constraints on this supply compared to, at least up until this week, vaccine. So I think it's something we should continue to think through about broader indications or not. So there will be ongoing conversations about this. And again, it's a limited distribution now, but if you as providers are interested, please do contact your local health department. We want to get this treatment into as many clinics as possible to increase access. Next slide. And then just as far as to give people a sense of the scale or numbers of how many vaccines we've gotten in the whole state of California, to date we've only gotten about 109,000 doses in California. The LA allocations are noted here separately because they get direct allocations. We do anticipate another allocation, what they're calling phase 3B, which will be another 30% or so of the next phase will come next week. And as many of you may have heard, I think there will be announcements likely this week or next week, the latest. There's a dose-sparing strategy that the federal government has worked through, which would be providing the doses intradermally rather than subcutaneously, and it would actually allow a smaller dose to be given intradermally, based on one study that does show equal antibody titers at least, and it would give us basically 5 times as many doses as the current use. So that's a really welcome strategy. We're starting to think about implementation issues in that. Obviously, training is a little bit different. It's more like giving a PPD than other traditional vaccines. So I think we'll need to work closely with all of you and local health departments on how to implement this. But it's a really, again, welcome news that we will likely be able to use this vaccine much more broadly as far as the number of people we can vaccinate. So more to come on that very soon. Next slide. And then really briefly on COVID-19, next slide. Just wanted to share, I share this every time I'm here. This is kind of our overall epidemic curve. You can see in the upper box the whole course of the pandemic, and then kind of narrowing in from May until now. And we have had this more recent sort of BA4, BA5 swell or surge in cases. It does seem like that is on the decline now. And thankfully, you can see that the deaths had slightly increased during that, but have decreased as well. And hospitalizations increased a bit, but are stable. And I think there are some signs of plateauing. So So while we did see a lot of transmission here in California with these new subvariants of Omicron, again, thankfully, the hospitalizations have been low and stable. So I think we are hopefully at the tail end now of this most recent surge. Next slide. And then you can also see this illustrated in the CDC COVID-19 community levels. As of last week, we had about 3/4 of our population in the high levels and about 1/4 in medium, which was progress. And we'll get more updates later this week. This is again based on not only case transmission, but also how many new admissions per capita are in these different jurisdictions. Next slide. And then again, want to continue to highlight therapeutics. We continue to want to increase outreach to providers about this as well, and for people to know that these treatments do decrease the risk of hospitalization and death. So again, Paxlovid as far as the oral, and then remdesivir are the preferred treatments. There's been a lot of interest in the question of rebound. I would want to point people, and there's a link on here to a recent MMWR that actually was done here in Southern California around when you actually carefully study this, as opposed to hearing anecdotal reports, there were less than 1% of cases who had been treated with Paxlovid who had any kind of rebound. But this continues to be closely studied. You know, again, more info will evolve on that. And here's a nice sort of spectrum to think about too, as you're thinking about your patients and whether or not to treat them with Paxlovid, who's lower risk and who's higher risk. And then we also wanted to make sure we kind of let you know now, and then more information will be coming on our websites and other places. We are working on getting some test to treat equity grants out, and there will be grants for providers as up to $1 million actually for things like showing that you've demonstrated workflows to get rapid treatment after testing positive, other ways that you're addressing equity, improving your health information exchange so you can really be tracking who's getting that treatment, including demographic data, and other things that really hoping to get that to really hope to improve the equity gaps that we're seeing in COVID-19 treatment. So wanted to highlight that. Next slide. And then just a word about Novavax. This is the newest vaccine that's been approved in the United States. It is now here and available for order. It does also contain the recombinant spike protein and an adjuvant. It's approved now for a primary series in adults, and the dose and interval is 3 to 8 weeks apart. It is also, like our other vaccines, safe and effective. And the frequency of serious adverse events was similar in vaccine and placebo, and it can be co-administered with other vaccines. That question's coming up a lot as we get into flu season and as we are starting to vaccinate people for monkeypox. It's not authorized to be used as a booster dose currently, and then there's some links in here for some other information, but just wanted to make sure you're all aware that it is here in California now if you want to request or order that. Next slide. And then I just conclude with just a little humor as I am needing to use for myself and thinking about the evolution of my role as a state epidemiologist and my epidemiology colleagues. You know, earlier on, people didn't know when I was initially a local health officer what an epi was, and now it's like, you know, we're trying to explain what we are, and it's been a busy 2.5 years, and now with monkeypox and other evolving things, I'm ready for epi to be boring again. But anyway, it's definitely been an eventful summer, and really glad we're able to leverage, though, a lot of the building of public health infrastructure and partnerships and relationships to be able to work on monkeypox as well. With that, I will stop and turn it over. Thank you so much.
Thank you so much, Erica, and it's really exciting to have you here to help us understand monkeypox as well. And now, again, we're so excited to introduce Dr. Offit. Paul Offit is a physician and the director of the Vaccine Education Center at the Children's Hospital of Philadelphia. He's also a professor of vaccinology and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania, which is my medical school alma mater. He's a recipient of so many awards that I'm going to have to encourage you to look up that impressive list rather than list them here. He's published more than 160 papers in medical and scientific journals, many around vaccine safety, and he's the co-inventor of the rotavirus vaccine, RotaTech. He was a member of the Advisory Committee on Immunization Practices, ACIP, to the CDC, and he's currently a member of FDA's Vaccine Advisory Committee, and he's a founding advisory board member of the Autism Science Foundation and the Foundation for Vaccine Research. Dr. Offit's also the author of 10 medical narratives. And I have to say, he's one of those rare people who can write nonfiction books that are extremely readable to a lay audience, as well as deeply technical scientific papers. We are incredibly grateful to have him share his experience and wisdom with us today. So take it away, Dr. Offit.
Thank you very much. So, as Dr. Green said, I'm a member of the FDA's Vaccine Advisory Committee. And on June 28th, we were asked to consider whether or not we would approve the use of a bivalent vaccine to be given in the fall. So I want to talk about that, but I think more broadly, I want to talk about booster dosing because I think that's incredibly confusing. I think I think if you ask 10 Americans, what does it mean to be fully vaccinated? You probably get 10 different answers at this point. So I want to talk about sort of the evolution of booster dosing and how we got to the place we are now. So next slide, please. So we'll start from the beginning. As you know, there was a virus, SARS-CoV-2 virus, that raised its head in October, November of 2019 in Wuhan, China. Next slide. And that virus was then isolated and sequenced in January of 2021, and its sequence was published. But that's, next slide. So the mRNA vaccines that are made by Pfizer and Moderna, and the vectored virus vaccine that's made by J&J, and the purified protein vaccine that's made by Novavax were all designed to prevent that strain, the Wuhan strain, otherwise known as the ancestral strain. Next slide. But that's not the virus that left China. The virus that left China and swept across Asia, swept across Europe, swept across the United States was the first variant. It didn't have a Greek letter designation. It was called D614G because it was really just one principal mutation that occurred at this sort of the amino acid site 614 of a protein, SARS-CoV-2 spike proteins, about 1,200 amino acids long. That one mutation from aspartic acid to glycine, so aspartic acid is D, glycine is G, made that virus much, much more stable and much more contagious, 10 times more contagious. That allowed that virus then to sweep across the world. Next slide. And so that's what's happened. I mean, what we saw, the first virus that we saw come into this country in sort of early 2000 was the D614G variant, which has been replaced by the Alpha variant because it was more contagious, which was replaced by the Delta variant because it was more contagious, which was replaced by the Omicron variant because it was both more contagious and more immune evasive, and we'll get to that, and now the Omicron subvariants. Next slide. So to what extent were these variant viruses susceptible to vaccine-induced immunity? Next slide. Which brings us to the central question, what is the goal of COVID-19 vaccines? Next slide. The only reasonable goal for this vaccine, this short incubation period mucosal respiratory infection, is prevention of severe illness. Even if the entire world were vaccinated and this virus never mutated to become another variant, we would still be experiencing mild illness because such is the nature of short incubation period diseases. So this is the only reasonable goal for this vaccine. Next slide. So in mid-December 2020, Pfizer's mRNA vaccine and Moderna's mRNA vaccine were approved for use in the United States. It's pretty amazing, actually. I mean, 11 months, from the isolation of the virus in January 2020 to presentation of our committee, FDA Vaccine Advisory Committee, in December of 2020, using a novel technology. We had two trials, one 40,000, one 30,000, which is the size really of any typical pediatric or adult vaccine phase 3 trial that showed remarkable efficacy. And the efficacy was against not only severe disease, but it was against mild disease. And I think that fooled people because we had 95% efficacy against mild disease in those two trials that were presented in December of 2020. But the reason that was true was those were 3-month trials roughly. So most people had just gotten their second dose. So they had high titers of neutralizing antibodies at the time of exposure. That had to change, and it did. I mean, 6 months later, you had a decline in efficacy against mild disease, as would have been expected. I wish we'd done a better job at that time explaining that that had to happen. Next slide. So 1 year later, however, both 6 months later and 1 year later, protection against severe disease was holding up against all variants, against the D614G variant, the Alpha variant, and the Delta variant. Next slide. So there were a number of studies that showed this, probably 6, 8 studies that showed this. The one I want to highlight is one by Mark Tenford out of the CDC that was published in Clinical Infectious Diseases in May, but it went through data up through December of 2020. So 1 year, December 2021. So vaccine comes out in December 2020, December 2021, next slide. The data showed that the protection against hospitalization showed that with 2 doses of an mRNA vaccine, as compared to people who were unvaccinated, the protection was holding up. So the median age in this study was 60. 81% of people in this study had at least one or more than one medical condition that put them at higher risk of severe disease. And this is Delta variant was predominant. So we're not in Omicron or the Omicron subvariant yet. This is still up through the end of December or the end of 2021. But if you look overall, there was basically 90% protection at 3 months and 82% protection at 9 months. For Pfizer's vaccine, it was 88% and 79%. For Moderna's, 93% and 87%. This is basically all comers. For the 18 to 64-year-old, it was 91% at 3 months and 87% at 9 months. And then for the greater than 65-year-old, again, 87% at 3 months, 78% at 9 months. So this is excellent protection against severe disease, is holding up 2 doses, 1 year against this virus. Next slide. And consistent with the epidemiological studies were the immunological studies. Next slide. So this is a study by Shane Crotty, but there are other similar studies by John Weary at the University of Pennsylvania showing that if you looked 6 months later, 12 months later, the frequencies of memory B cells, the frequencies of memory T helper cells, the frequencies of memory cytotoxic T cells were all holding up. So the epidemiology was consistent with the immunology. Next slide. And so a way to think about this is there's different stages of this illness. In the first stage, the virus reproduces itself, and then you make an immune response. The good news is that it actually takes a while to develop severe disease. So although neutralizing antibodies will fade over 3 to 6 months, memory cells generally are long-lived. The problem with memory cells is it takes time for them to become activated, differentiate, and then become effector cells. Effector cells meaning antibody secreting cells, or in the case of T helper cells, cells that help B cells make antibodies, or in the case of cytotoxic T cells, which are critical, I think, for protection against severe disease. These are cytotoxic T cells kill virus-infected cells. So it does take time for those cells to become activated and differentiated, but the good news is it also takes time to develop severe disease. So that's why you can have reasonably long-lived memory, and therefore reasonably long-lived protection against severe disease. And that's what we were seeing 1 year later. I think it will be interesting to know how long that memory holds up. And hopefully the CDC and the immunologists will give us the kinds of data that allow us to answer that question. Next slide. So another way to think about memory cells is to think of them as the sort of fire extinguisher in the kitchen. Next slide. So the goal of the fire extinguisher is to put out the fire once it starts in the kitchen, but it's not to prevent the original fire. In other words, so the fire sort of representing mild illness. The goal of the fire extinguisher is to keep your house from burning down, being sort of the analogy for severe disease. And so that is what memory cells can do, but they're not going to prevent mild illness. And when you have a short incubation period, knowing that with SARS-CoV-2, the incubation period can be as short as 2 days. Typically it's 6 or 7 days, but it can be as short as 2 days. Knowing that neutralizing antibodies fade, knowing that in order to be protected against mild illness, you need high levels of neutralizing antibodies. Therefore, you have to, by definition, experience mild illness over time, which is what we're seeing, and that's okay. I think when people have been vaccinated and then get a mild illness, they won. And I think we could have done a much better job of explaining this, because if you look at what happened back in July of 2021, there was an outbreak in Provincetown, Massachusetts. So thousands of men get together, they celebrate the July 4th holiday. In that, there was about 80% of those men were vaccinated, had received 2 doses of mRNA-containing vaccine. Nonetheless, there was an outbreak. And when that outbreak occurred, there were 346 men who, despite being vaccinated, got COVID. 4 of those 346 were hospitalized. That's a hospitalization rate of 1.2%. That's a win. That's good. That's what you want. That's a vaccine that's working. The remaining 342 men had either mild or asymptomatic illness. that was unfortunately, and it was in the title of this article in MMWR by the CDC, it was the birth of the term breakthrough illness. Those weren't breakthroughs. Breakthrough implies failure. That's not a failure. That was a win. I mean, if you watch the way that the news carried that story, and very soon after that, Supreme Court Justice Brett Kavanaugh had an asymptomatic infection, which was called a breakthrough. And you know, if you watch this on television just casually, you would assume it was fighting for his life in the intensive care unit. I mean, it was the wrong use of the term. We just inadvertently, very early, damned this vaccine by using that term breakthrough. Next slide. Okay, so now we're a year later, December 2021, and Omicron hits. Next slide. Omicron, unlike D614G or Alpha or Delta, which had a handful of mutations, Omicron had like 30 mutations, 15 in this receptor binding domain alone. This was a drifted virus. I don't think anybody would have predicted that a coronavirus like SARS-CoV-2 would, in a sense, act like flu, where the virus drifted to the extent that you really had reduced neutralization by the sera that was generated by these mRNA vaccines. The neutralizing antibodies were less effective. So the question then is, did memory hold up? Did memory hold up against Omicron and then what we now know to be the Omicron subvariants that Dr. Pond just mentioned, BA4, BA5, BA2, 121. So next slide. And this just shows the sort of the rise of Omicron. Next slide. And so there was clear, for the first time, we saw clear immune evasiveness. So even if you'd been vaccinated, if you've been recently vaccinated, you could suffer a mild illness. Next slide. And that's all because you had, as you can see here, this was after 2 doses of Moderna's vaccine, while you had excellent neutralizing antibody against a variety of these variants. That wasn't true for Omicron or one of the Omicron subvariants you see on the right-hand portion of this slide. Next slide. And hence we had the birth of the first booster dose. I mean, this is with this, we now said, okay, we need a third dose. And at the beginning of this pandemic, back in December of 2020, I remember having conversations with people like Dr. Fauci and Stanley Plotkin, I mean, leading lights in the world of vaccines. And they said at that time, they thought that, that in order to get high frequencies of memory B cells, memory T helper cells, memory cytotoxic T cells, we were going to need at least 4 to 6 months between doses. And when we launched this vaccine, as sort of where the intervals were 3 weeks, say for Pfizer's vaccine, or 4 weeks for Moderna's vaccine, they felt that we were always going to need a third dose. But at least up to a year later, there wasn't evidence for that. Memory was still holding up. But in any case, this led to the birth of the first booster dose. Next slide. And if you look at the slide here, you can see that there clearly was an advantage for the third dose, for those who received the third dose, even those who were younger who received the third dose as compared to a second dose for protection against hospitalization. But I think the important thing here was not that a third dose was of value in Omicron for protection against severe disease. Next slide. But who it was of value for. It wasn't everybody. I mean, it really was primarily those who were the elderly, as Dr. Walensky occasionally uses the term, the elderly, meaning those over 70, those who were long-term care facilities, or those who had, significant illness like chronic lung disease, chronic heart disease, chronic neurological disease. And I think what's happening here is not a loss of memory. I don't think that's what's happening. I think what's happening here is that some people, because they are basically immune incompetent, which is to say the elderly or those who are immune compromised, or those who have significant enough diseases like out of control diabetes or chronic heart disease or chronic lung disease, they can't handle even a mild infection. That when they get a mild infection, it's much more likely to go on to a moderate or severe infection. And so therefore you're trying to prevent even that. And I think that's really what was happening here. Next slide. Then we had the birth of the second booster dose. Next slide. Here the data were thinner. You can see if you look at sort of on the bottom portion of this slide, the purple line represents sort of the primary series in 2 or more booster doses, and then the light blue line represents the only the 2 doses, and then the primary series and the booster doses, the darker blue line, there was a difference here of about fourfold in risk for hospitalization. But the actual numbers of people who were protected were relatively small. And again, next slide. It was those who were most at risk. I mean, so I think it makes sense to boost those, especially as you're heading into, say, months when the disease is likely to be greater, which has at least the past 2 years been the winter when it seems to peak more, although this virus clearly can circulate throughout the year and even sometimes can increase wildly when a new variant comes in during non-winter months. But I think it makes sense to boost the high-risk groups, the elderly, those who are, and as I'm getting older, it's getting harder and harder to say the word elderly, but the elderly, people who are immune compromised, either because of the drugs they're taking or because they were born with immune deficiencies, and then those who have really pretty serious diseases that put them at risk of disease. But I think for a healthy young person, it really, this booster mania has not been of value and has been confusing. Next slide. Okay, so on June 28th, we, the FDA Vaccine Advisory Committee, were asked to consider this question. Do we need a variant-specific vaccine in an era of immune-evasive Omicron variants? And specifically, the question we were actually asked is, would we agree with a bivalent vaccine to be introduced in the fall, September, October, that would have the ancestral strain, the original strain, plus the Omicron, which was BA1? And I'll get to how this played out, but I voted no on this. I'll sort of explain why I voted no and then tell you sort of how I think this is going to play out. Next slide. So Moderna's bivalent vaccine, next slide, was if you look at the bottom portion of this slide, what that was, they did a trial where they took people who had already gotten 3 doses of the ancestral vaccine and either boosted them with a 4th dose of the ancestral strain vaccine, or boosted them with, which was 50 micrograms of the ancestral strain vaccine, or they boosted them with 25 micrograms of the ancestral strain plus 25 micrograms of the Omicron variant BA.1.1.529. Next slide. And what they found, if you sort of look in the middle portion of this slide, was that when you compared those two, that those who got the bivalent vaccine had neutralizing antibodies that was 1.75-fold greater than those who had gotten boosted against Omicron, as compared to those who were just boosted with the ancestral strain. Next slide. Pfizer also looked at a bivalent vaccine. Next slide. And what they did was they either used 30 or 60 micrograms as their Omicron containing vaccine. So again, it was ancestral plus Omicron. They also did a monovalent boost, but we'll just focus on the ancestral plus Omicron as compared to ancestral only as a 4th dose. Next slide. And what they found was that they had, if you looked at the 30 micrograms, it was the bivalent vaccine, it was either roughly 1.5 up to a little less than 2-fold greater neutralizing antibody titers against Omicron as compared to just boosting with the ancestral strain. So those were the data that we were presented. Next slide. So here are the arguments, I think, against a bivalent vaccine, including Omicron. Next slide. First, the 1.5 to 2-fold increase in neutralizing antibodies, while statistically significant, is unlikely to be clinically significant. Next slide. When these vaccines launched, the 2-dose vaccines for Pfizer or 2-dose vaccines for Moderna launched in December of 2020, Moderna had about a 2-fold greater neutralizing antibody response, but that didn't play out to be a statistically significant greater response in terms of protection against severe disease. So I would argue that neutralizing antibody difference was not likely to be clinically significant. Next slide. Also, Omicron has been replaced by the Omicron subvariants, and the question we actually were asked was Omicron, which was BA1. Next slide. Yeah, and this we've already showed you that BA5 and BA4 and BA2.121 has replaced BA1. Next slide. And I think the next slide shows the same thing. It's just greater. This is more recently. So next slide. Also, boosting with the ancestral strain increases neutralizing antibodies against BA4, BA5. That 3rd dose that you get does broaden your immune response. This is sort of one of the good things about using the ancestral strain is it does broaden the response with that 3rd dose. third dose. Next slide. And this was a paper that was published, I think, the end of June, the end of June by Linda Safe and co-workers in the New England Journal of Medicine. Next slide. So they took healthcare workers who received 2 doses of vaccine and then boosted them with that third dose. But you can see that with that third dose, there was a clear increase in neutralizing antibody titers against BA1, which is Omicron, as well as the BA subvariants, including BA4, BA5. So that's why you do the controlled study. That's why you have to have that ancestral boost as your control, because that does boost neutralizing antibodies against BA4, BA5. Next slide. And also, animal model studies have failed to show an advantage of an Omicron vaccine versus the ancestral vaccine following an Omicron challenge. Next slide. So this was a study out of Bob Cedars' lab at NIH, and what he did was he then looked at sort of 2 doses of the mRNA-containing vaccine. It was Pfizer's vaccine, and then boosted with either Omicron or boosted just with the ancestral strain. Next slide. And found no difference. Equivalent control of virus replication in lower airways was observed following Omicron challenge 1 month after boost. So he boosted with Omicron or boosted with the ancestral strain and then challenged with Omicron, but there really was no difference. There was comparable immunity and comparable protection. So that also didn't support the notion of this bivalent vaccine containing Omicron. Next slide. Nonetheless, the day after we met, the U.S. Department of Health and Human Services put out this press release that they were going to purchase at least 100 or so million doses of Pfizer's vaccine with an option up to 300 million doses. I think the way this is going to play out is that there will be a bivalent vaccine that is going to be available in September, October. That bivalent vaccine will not contain Omicron as BA1. It'll contain the Omicron subvariants as BA4, BA5, or either BA5 alone, BA4 alone, BA4, 5. We'll find out. All I'm asking you to consider is that before you give that vaccine, you should look very carefully at the data to show that they're at the best case scenario is that there's a clinical difference between receiving a bivalent vaccine as compared to a monovalent vaccine. But at the very least, a much more dramatic neutralizing antibody response different to BA4, BA5 as compared to just getting the monovalent vaccine alone, because this is a new product. And I think it really needs to be thought of as a new product. And I think that when we approved largely the idea of a bivalent vaccine, it was not with a data that was terribly convincing. So I'm not saying that it's a bad idea. I'm just saying that we should hold this idea of a bivalent vaccine to the fire to make sure that we have clear evidence that it's of value, because there's always surprises. I think that's what, if anything about this virus and this vaccine should be learned from the past couple of years, it's that nature gives up its secrets slowly, grudgingly, and invariably with a human price. The myocarditis was a surprise. I think thrombosis with thrombocytopenia syndrome was a surprise. Pericarditis was a surprise. I think there is invariably a human price that comes with medical innovation, and I think whenever you have a new product like this, just be humble and make sure that you don't launch into something because it sounds like it's good when it not necessarily, you don't have evidence that it clearly is good. So I will stop there, and thanks for your attention.
Thank you so much, Dr. Offit, for that very interesting and deep research of the data. Erica, do you want to pop on with us and we'll ask a few questions? I'll go ahead and start with you, Dr. Offit. I'm really, really grateful that you were here to tell that inside story. We did have a number of people whose questions before they signed on were about why you did that vote. So I think it's pretty clear what that happened. Let me just ask you some pretty simple sounding questions, but I think many of us, even physicians and other healthcare providers, still have them. So we've heard a lot of this word along the way about people trying to develop a universal coronavirus vaccine. What is that? How would it work? Is that possible? Can you talk a little bit about that?
Right. Not a novel concept. We've been trying to make a universal flu vaccine for about the last 50 years. I actually trained in a lab at the Wistar Institute that was working on a universal flu vaccine in the early 80s using the matrix protein. So I have a healthy respect for how hard this is to do. So it's a great idea. That way you would have sort of a variant-proof vaccine. There's two ways to do this. One is to try and find a conserved region that that is found in all of the variants to date, with an understanding that new variants would also have this conserved region, and that you could then be protected. That historically has not been something that's worked. It certainly hasn't worked with the influenza vaccine. It hasn't worked with human immunodeficiency virus vaccine. So I'm pessimistic that that could work. The other thing you can do is, and this is out of Walter Reed National Military Center, they have you have sort of like the soccer ball onto which you attach a variety of spike proteins, you know, that in the hopes that this will include sort of all the current circulating variants, and that in that way, if these other variants that are, say, circulating in other countries come here and start to predominate, that at least you have a heads up. So I think that's the thinking, the so-called pan-sarbecovirus vaccine. We'll see. The other strategy that people are talking about is as better is a nasal spray vaccine. Kiko Iwasaki at Yale University is working on this as well as others. The advantage of that is that you induce antibodies, secretory IgA at the mucosal surface, the nasal mucosal surface. You also induce memory cells in nasal-associated lymphoid tissue, so-called NALT, so that when you then are infected, you are getting much more local immunity, which can then presumably decrease your shedding to a greater extent and make you less contagious. Again, not to be a skeptic, I just think that, again, it's a short incubation period disease. You have, as a general rule, effector functions at mucosal surfaces are short-lived. That's certainly true with rotavirus, and, which is another short incubation period mucosal infection, albeit an intestinal infection. So you can have long-lived memory cells and nasal-associated lymphoid tissue. You can have that, but it still takes a while for those memory cells to become activated and differentiate. So I would be surprised if it really had a major impact on shedding. I mean, as much as we heralded flu mist, it hasn't exactly been a game changer.
Yeah, that's really helpful. Speaking of flu mist, or flu rather, do you anticipate that there will be, people are wondering, a combination flu and COVID flu vaccine with a COVID booster coming up this fall?
Yeah, I'm glad you asked this question, which has become a pet peeve of mine. I feel like, the companies, Pfizer, Moderna, Johnson & Johnson, have become public health agencies. I mean, they sort of tell you what they have. We're working on this. We're working on a booster dose. We're working on this combination vaccine. In a better world in which we're currently apparently not living, this should all come from the CDC. I mean, the CDC should say, but the only reason to do that is because you want to have a yearly booster dose. And I think that may be of value for certain groups that are at high risk. But I think, we have a flu vaccine that is recommended for everybody over 6 months of age. And I don't really see that a healthy young person really needs that yearly booster, assuming that memory holds up and assuming that protection against severe disease holds up. Unless we're trying to protect mild illness. And if you're going to do that, then you're going to have to vaccinate a couple times a year. And even that is not going to make probably a big difference. And the good news is, because I don't mean to be just a complete naysayer during this talk, the good news is I really do think we're getting there. I mean, if you look at sort of the level of population immunity you have now with either natural infection or vaccination or both, you're probably at least in the 85 to 90% range at this point. And you're seeing that. I mean, you know what, when you see these sort of increase in cases, say with BA5, BA4, you're not seeing nearly the increase in hospitalizations and death that you were, which means you're getting protection against severe disease, which is what you want. I mean, I understand it's not fun to have a mild illness, but for otherwise healthy people who can handle a mild illness, live with it. So I know that you probably can't say that as public health people that sort of live with the thing, but I can, because I'm not really a public health person. I just work, as an FDA advisor.
That's why we invite various voices, and we'd love to have yours. Speaking of those memory cells and how long they're going to last, you talked about that data a year out. Are we going to get 18-month data? Are we going to wait till the end of 2022 to get the next data? When are we going to hear about the sort of persistence of these memory cells?
Hopefully, we should constantly be generating those data. I mean, I think
so it's not been published yet. You haven't seen any.
good news is we have, a wonderful head of the CDC. I mean, Rochelle Walensky is great. She's a brilliant scientist. She's a great educator, and I think she's a really good voice on television. I wish they'd let her talk more, frankly, because she's clearly empathetic. And we have talked about that. I mean, and she knows this. It's not like I had to say anything to her. It's because, she knows all this anyways. We need to generate those data because that really is what guides things. I mean, really, do we need booster doses? And if so, who benefits from booster doses? And how often are we going to need to be vaccinated? And those are the data you really need. And when people are hospitalized, just make sure that we know that they're hospitalized, for COVID and not with COVID. And that's been a problem to some extent. And you look at the UK, for example, tried to separate that out as people requiring oxygen, and you found that the numbers dropped if you used just that as a minimal criteria.
Okay, great. Let's move a little bit to the new the Novavax vaccine that we've talked about a couple of times. We had an interesting question about someone, a physician actually, who received the J&J vaccine and booster. And now needs a new booster. And this person sort of feels that the J&J was not good enough protection and is wondering if as a booster she needs an mRNA booster or should she get Novavax this time? How do you think about this sort of mix and match approach? Any advice there?
So I think if you're a healthy young person, that 2 doses is probably enough to give you fairly long protection against severe disease. I think that if you fall into those other categories, it's reasonable to get another dose. In terms of mixing and matching, I think in the end that probably will be Novavax's initial niche, which is as a booster dose for the mRNA vaccines. I mean, a much smaller percentage of the population has J&J's vaccine, but I know Novavax is in the midst of doing studies where they are looking at that. I mean, right now it's a 2-dose vaccine. They're in the midst of studies looking at it as a 3-dose vaccine, and we'll probably have those data soon. And I know that they're doing studies looking at it as a booster dose for the current mRNA or vector virus vaccine. So we'll have those data soon. I imagine they'll be good. I would predict they would be good. I mean, Novavax. Dr. Pond said this, the advantage of Novavax is that matrix M adjuvant. I mean, that is a powerful adjuvant. It's a sapinin-based adjuvant. It's the same as one of the 2 adjuvants that are in Shingrix, which is probably the first example ever in the history of having a subunit vaccine being better than a live attenuated viral vaccine. I mean, the Shingrix is better than Zostavax was, and it's because of that adjuvant, that QS21 adjuvant, so-called matrix M, and plus they have monophospholipid A. But I mean, if you look at the data for that vaccine in like the greater than 80-year-old, it's still great. So I think that's the advantage of Novavax's vaccine. It really does seem to have broadened immune response. So I'm optimistic that as a booster dose, it will be excellent.
And Erica, I'd love to hear your point of view about whether, and also you, Paul, about whether this new vaccine is going to enhance uptake in people who have been a little bit more resistant to the idea of the brand new mRNA technology and the safety and things. Do we have early indicators of that yet? I mean, I know it's a hypothesis.
We certainly, pre it coming out, had a small amount of survey data suggesting that there's a small proportion of people who are holding out for this vaccine because there was more history with it. And it's really, I think it's pretty early, at least in California. I think we literally are just getting it here. And I know as far as orders from providers, but that's different than administration, people have ordered about, I think, less than a third to a half of sort of what's available. So I think time will tell. It'll be interesting. I do think there is a subset. I just don't know what proportion it is. And yeah, Dr. Offit might have other more national perspective on this.
Yeah, and so the thinking is, we've been using purified protein vaccines ever since the hepatitis B vaccine in the early 90s. So you have 30 years of experience with a purified protein vaccine. And so people were saying, well, I'm going to wait for this tried and true technology. First of all, the mRNA vaccines were probably the best studied vaccine in history. They've been in billions of people. Marie Silliman, who was the father of modern vaccinism, he's the inventor, or at least primary, either inventor or developer of 9 of the 14 vaccines we give to children. He said it best. He said, quote, "I never breathed a sigh of relief until the first 3 million doses were out there, where the first 3 billion doses are out there, and we know exactly what the safety profile is." So I don't know. We went through this actually when we went from EUA to full licensure. People were saying, it's still under emergency use authorization. I'm going to wait till it's fully licensed. And then it was fully licensed, and it's not like there were lines around the block. So I think these are straw man issues, but.
Yeah. Okay. Well, why don't we move to pediatric vaccines for a minute, since we're all trained in pediatrics here. Can you talk a little bit, Paul and/or Erica, about the risks and side effects of vaccines in our youngest cohort? What's the data coming out now that it's out, and any other thoughts you have just about the experience of this sort of 6 months to 5 years?
You want me to start, Erica? You want to start?
Yeah, I'll let Paul. I'll defer to you.
So it was worrisome. You knew that surprisingly, that the 16 to 17-year-old had myocarditis, a male 16 to 17-year-old, primarily after the second dose, primarily within a few days of the second dose, had an increased risk of myocarditis. The good news was it tended to be transient, self-resolving, without any clear evidence of sequelae. So that's good. That was good. So you worried, at least we worried on the FDA Vaccine Advisory Committee as we went to younger age groups. So we did the 12 to 15-year-old. What ended up happening was, so there were data both in Israel and the United States, that the incidence of myocarditis was actually less in the 12 to 15-year-old, but it still occurred, but it was less. Then you went to the 5 to 11-year-old, and it was also less. After the first million doses were out there, there were cases, but it was much less. And now we're generating data for the less than 5-year-old. But I think that was reassuring because you didn't really know why was it that it was that 16 to 17-year-old. And it went up to really the increase in 16 to 29-year-old, but it really wasn't seen as frequently in the older age groups. So you always worried as you got to younger age groups that it would be, but that wasn't true. So other than the usual things you see, pain, redness, site of injection, fever, headache, joint ache, et cetera. It's nothing has popped up yet because you always hold your breath. You do. You never know until, again, millions of doses are out there. But to date, things look pretty safe.
I think the only quick thing I would just add, thinking about a little bit of the epi too, is that, so we've only got under 40% or so of the 5 to 11-year-olds vaccinated. And of course, that vaccine's been out longer. And then, it's a very small proportion of the under 5s. And I do hope that, this message about the safety and effectiveness continues because, where we actually did see more hospitalizations were in that younger under 5 age. So, similar to sort of flu, right? Sometimes you see the more serious in that U-shaped curve of the extremes of life. So I do hope that we can continue to get parents out there vaccinating their kids. And, I appreciate again that Dr. Offit's always so good at kind of explaining this. Yeah, once the first 3 million, and I've been saying a lot about vaccines, it's like we've never accumulated so much safety data so quickly. Like it's pretty amazing actually, right? How many millions of people have been vaccinated in such a short period of time, and how robust our safety detection networks are. So yeah, hope we can get more of those kids vaccinated.
Yeah, can I just have one other thing? It's when we consider the vaccine for the 5 to 11 year, you're always making decisions under uncertainty. You never have all the data you need. You are trying to make the best of the data that you have. You never have all the data. Frankly, you never have all the data. You're just trying to make the best with what you have. But when we met, right before we met for that 5 to 11 year old, we got thousands of emails. Each of us that were voting members got thousands of emails from people basically saying, really, you're basing this on a study of 2,400 children? Here, when we did Pfizer's vaccine, Moderna's vaccine for adults, we did 40,000 people, 30,000 people. And now you're basing this on a study of 2,400 people. That's not enough. And I just want to argue the other side of this. There is always a human price paid for knowledge, and it works both ways. So, for example, I'm old enough to remember the polio vaccine, but when Jonas Salk made his polio vaccine, he took the virus, grew it up, purified it, killed it with formaldehyde. A coal-killed viral vaccine. He tested it in 700 children in the Pittsburgh area. As far as he was concerned, he had it. Eureka! I've got it. We've got a vaccine. He didn't want to do anything more than that other than mass produce it and distribute it. Nonetheless, there was an insistence on a clinical trial. And so there was the so-called Francis field trial. 420,000 children got the vaccine, 200,000 got placebo. He thought it was unconscionable. He thought it was unconscionable to give a child salt water, a first and second grader in the mid-1950s, knowing that every year 20 to 30,000 children would be paralyzed by polio and 1,500 would die. He couldn't conscience that. So to sort of satisfy him, they also had 1.2 million observed uninoculated controls, which is all he wanted. He didn't want to vaccinate a child with salt water. And so when Thomas Francis made that announcement, right, safe, potent, effective, and those three words reverberated across this country, headline of every newspaper, you know, department stores stopped where they made that announcement when he made his announcement at the University of Michigan. Every newspaper had that headline, and church bells rang, and synagogues had special meetings, and so how did he know it was effective? How did Thomas Francis know that vaccine was effective? He knew it was effective because 16 children died in that study, all in the placebo group. He knew it was effective because 36 children were paralyzed in that study, 34 in the placebo group. Those were first and second graders in the 1950s. I was a first and second grader in the 1950s. Those children could have lived long and productive lives, but for the flip of a coin. And that's always the other side of this. There were children who did suffer COVID who were in the placebo group in those studies. And those parents, I give them a lot of credit for entering their children in those studies. Those are the sort of these gentle heroes that we never really talk about. But there is always a price to pay both ways.
Thank you for sharing that. Such important stories. As we move towards the end of our time, I'd love to hear both of your thoughts. Erica, as a public health leader who's really making these decisions actively, and yours too, Paul, about how we think about back to school vaccine requirements in kids.
And is your question sort of overall, like back to school?
Yeah, well, what's California going to do? Are there going to be vaccine requirements as children are getting ready to go back to school, to enter school?
So
for COVID vaccines, sorry.
For COVID vaccines, right. So as you sort of know, I think we at one point we're going to do that. At this point, we'd have to be starting now, actually, if we were going to do it from the public health side for even the 23-24 year. And then the other method, of course, for this to become a vaccine requirement is through the legislature. So what I will say is, you know, and I think this comparison needs to be made much more often. If you look at other vaccine preventable diseases, including, and especially actually the ones we require for schools here in California and in many states, this disease causes a lot more, you know, hospitalizations and deaths than pretty much most of those, even for those diseases that were pre-vaccines. So I do think it's really important as another vaccine preventable disease. But I think as far as, you know, it's definitely not going to be required during this school year. And I think time will tell what will happen over the course of the next academic year here in California and certainly nationally, I'm sure. But.
Yeah. And Paul, what's your view? Should there be vaccine requirements for kids to go to school for the COVID vaccine specifically?
Well, in a better world, we shouldn't have to require vaccines. Parents would look at the data and they would do the right things for their child, which in this case would be to vaccinate them. Again, that's not the world we're in. But I think the following facts are true. I think this virus is going to be with us for years, if not decades. I mean, if you look at the 4 strains of human coronavirus that are circulating, those first 2 strains, which were identified in the 1960s, one came into the human population in the late 1700s. The other one came into the human population in the late 1800s. They still circulate. They still can cause serious illness. They've never mutated to the point that they don't cause serious illness. So let's assume this virus is going to be with us for a while. Let's assume that children grow up, right? I mean, so at some point they're going to have 2 choices, which is to either be vaccinated or be naturally infected if this virus continues to be as contagious as it's been. So you'd like to think, see, what worries me the most in this is my biggest fear in all of this, is that the anti-vaccine movement never really had a politics. I mean, it was sort of like, you know, all things natural on the left, you know, just I just don't want to be, I don't want to be inoculated with, you know, with these adjuvants and manufacturing residuals and et cetera, et cetera, et cetera. So it was always kind of like kind of purity on the left and liberty on the right, if you will, you know. So don't tell me what to do. It's my body, bodily autonomy. I don't want the government tell me what to do. And see, that's what's happened. to the anti-vaccine movement now. They have linked to the right. I mean, when you see Del Bigtree, also at that January 6th insurrection day, also having an anti-vaccine rally just a couple blocks away, they have been embraced by the right under this sort of bodily autonomy business. Although bodily autonomy seems to go out the window when you're pregnant, but in any case, this is what they're sort of arguing for. And you see there's two United States senators that have actually said, one in Ohio, one in Texas, that that made statements about how they think vaccine mandates shouldn't happen anyway for any vaccine. And that's what worries me about this, that we've sort of leaned into this left hook of the right, where they are really against mandates, not just for this vaccine, but I think it may spill over in other vaccines. I hope I'm wrong, but I fear that.
Well, ending with the left hook from the right, I really, really appreciate you both being here tonight, as always. Erica, thank you for the update on monkeypox and the hard work on that. And we are very excited for when your job becomes boring, and yours too, Dr. Ovid. But thank you for coming, and thank you to all of our attendees for coming and getting educated. We look forward to seeing you next month. We will send that survey to get your CME, and our next session will be Tuesday, September 13th, and we will discuss the cardiac manifestations of long COVID then. So you can see the broadcasts of these and register at covidroundcia.com, and thanks again.
Thank you so much.
Thank you.